Hello and welcome to Horizon Medical Education Podcasts. As we record this episode, the world is once again responding to an Ebola outbreak. The current outbreak affecting the Democratic Republic of Congo is caused by the Bundibugyo virus, a less common strain of the Ebola virus for which there are currently no licensed vaccines or specific treatments. It's also an important opportunity to reflect not only what we've learned about the disease, but also on the experiences of the clinicians who cared for patients during the largest Ebola epidemic in history. I'm Minnie, and today I'm delighted to be joined by Dr. Yusuf Tejan, currently Senior Registrar for the Ministry of Health in Sierra Leone and Medical Superintendent at Bo Regional Hospital and long-time Horizon Medical Education friend. During the 2014 to 2016 Ebola outbreak, Dr. Tejan worked on the front line in Sierra Leone, caring for patients throughout one of the most challenging public health emergencies in recent history. Dr. Tejan, thank you so much for taking the time to join me today.
You're welcome. Thank you.
So let's start by taking you back to 2014. Can you tell us a little bit about what you were doing, where you were working when Ebola arrived, and what those first few weeks were like?
Yeah, thank you very much. In 2014, I was in medical school, the College of Medicine and Health Sciences. And in my final year, the whole course, like other schools, tertiary institutions, we are closed down during the Ebola outbreak in Sierra Leone. And of course, that followed when we lost one of our only infectious disease consultants, the late Dr. Khan, blessed memory.
Oh, so that was to the Ebola virus, was it? Oh.
Yes, so he was actually the first medical doctor that actually died in Sierra Leone. And that death was also followed by other 10 medical doctors and so many other health care workers. So the school was closed and the whole country was in chaos and panic because of the level of preparedness, I believe, right now. And I was equally just seated home, not doing anything. But there came a time when the need for support, human resource to respond to the outbreak heightened. And medical students and other social workers actually volunteered. So I had the opportunity to actually volunteer to serve as a community and treatment center surveillance officer. And I actually supported a lot of other teams, worked with so many partners, so many NGOs, including MSF, WHO, CDC, and a lot more. Yeah, so technically that was what I did till the end of the Ebola.
So at the beginning, when you were still at medical school, did it take a long time for the country to realise that there was an Ebola outbreak? At what point did it sort of become obvious that this was something different than just another, infectious disease like malaria or something?
Yeah, I think the three countries, Sierra Leone, Liberia, and Guinea, of course, we are the most affected countries. But initially, when we had our first case, that was in the eastern part of Sierra Leone, we had the first VHF treatment unit. I think the country, the health system, and a lot of people didn't take it serious. So it was just initially treated like any normal disease per se.
Yeah.
But again, because of the capacity we had at then, we were not prepared and we didn't have enough infectious disease specialists, consultants, and public health officers. We are in that, and clinicians, we are just focused on treating other normal and common disease conditions until the one and only infectious disease specialist consultant that we relied on nationally actually died of the disease. That was when the whole country went into chaos. Because most of the interventions, as I can understand now in states, we had like community engagement, the different response team. We are still ongoing, but at the baseline until we had that incident.
Yeah, because it's quite similar in some ways to what's happening in DRC with the confusion initially when it's all happening within a conflict or a displacement area. It must be so hard to work with the community and help the community understand what's going on, especially when you're asking them to do things like, change their practice in the way that they're living.
Exactly. I totally agree. And of course, and when during the response, these were the critical areas because, as we say, disease outbreaks that actually spread within communities, it should be responded to by the communities. So, which means the community needs to understand, believe, and adhere to the prevention strategies. They need to understand that they should build their capacity to actually stop the spread. Because most of the infection prevention and control measures that is being passed on by the communication officers, okay, works very well when the community stakeholders actually believe and follow. Because when we had sometimes when you have infectious disease being spread in communities and the crops are being taken care of by the communities, the other rituals are being performed on these bodies. So it actually contributes to the spread of the disease among all parties that actually come in contact.
Yeah, it can be so impactful, can't it?
Exactly. Households, families, communities, will be affected the most if they do not adhere to these preventive measures.
During the outbreak in Sierra Leone, how did you handle particularly things like the burial practices? How did you manage to convince the communities that things needed to change to keep everyone safe?
So at the initial stage, it was quite tough because the risk communication and community engagement teams, together with some other stakeholders, had several meetings, like the religious group, the cultural groups, the risk com team at the technical level had meetings. And we are actually passing on some of this information for them to adhere and stop this spread. However, some still continue doing those practices. But the punch line, the heightened points, was when a whole community, a whole household was wiped off as a result of one practice. So I will say the key experience during the 2014 Ebola outbreak was actually the icebreaker to community adherence to some of the practices, irrespective of all the efforts that the government and other technical teams were actually applying. So it actually validated.
It really brought it home to everyone when it was a whole family that died.
Yeah, exactly. So this happened actually in multiple communities. And communities that actually adhere to some of these advice, we are able to actually manage to handle the disease, more effectively, and then the community spread early compared to other communities, especially in remote settings.
Yeah, I mean, it's very difficult to reach people in remote settings, isn't it?
Yeah, it is really difficult because in remote setting, the likelihood, and in remote setting, the community behavior, the community structures is quite different from the urban settings. In remote setting, a whole village could just act as one household. So it is highly likely that when someone gets sick, that person is more likely to infect a whole lot of people in the village. So compared to urban setting, where maybe just a house will be affected, there'll be a lot of variations in the attributes of the residents in the households and other. So that actually brought a lot of complexities in responding to the disease outbreak in remote settings and making it really difficult to break the chain.
And when you were working, you said you started off as a surveillance officer. So what did you have to do? And did you have to wear PPE and that sort of thing?
So we are trained at all levels to put on PPEs, how to enter a community, how to investigate a case, how to fill case investigation form and everything. So when I started working, I was working as disease surveillance officer at MSF Switzerland in Freetown. That was in Prince of Wales School in Freetown. So I was the technical person at the walk-in stations when patients are being brought by the ambulance. And we ask them questions, we fill a case investigation forms, then we pass on the message to the lab to come and collect samples. Then we redirect them to the different isolation units at MSF. And there had been instances where I had to put on PPE and to perform one or two tasks. Just to ensure I am not exposed to any of the viruses, especially from people who have been suspected. But at most of the point, I did not directly deal with confirmed cases because confirmed cases were managed by the case management team. and I was just working in the surveillance department during the outbreak. So, but we had a lot of interactions. So as a result, I had to be very sensitive, all of us, to see the level of interactions and what you must and must not do during that period so that you don't get exposed as just a volunteer. Yeah.
I mean, it seems like a silly question, but did you feel concerned about your own health at the time? Were you worried that you might contract it and take it home to your family, or did you put that out of your mind when you were working? How did you cope with that situation?
The mental health issue related to you working at Ebola treatment center or in the community that are affected the most is huge. When I started working, the place where I stayed, I was technically isolated. I mean, no one enters my room, and the food prepared for me is being left at my door. And colleagues were not visiting me anymore. They said I was working at the treatment center,
Gosh.
and I could understand. And I also became very anxious at some point during my work. I check my temperature, and when my head aches or anything happens to me, I became highly sensitive, and that was quite a stressful moment for me. At least within the first few months, about 6 months, yeah, it was not easy for me, but I had to cope because for me, my belief was that the work I was doing was a national call. I was just a volunteer because the need was there. They needed people who could support the team, like WHO, Africa CDC, and US CDC, different partners that we are around that came, provided technical guidance. They needed people on the ground who can speak the local language, who can
and were trusted by the local community.
Exactly. Local community, exactly. So for me, what I could still reflect on strongly during the response was the passion, the nationalism I had, because looking at the number of healthcare workers that we are dying, hundreds of nurses, doctors that we are dying, people that we are dying, over 4,000 people that died. It was a national call, which I reflect strongly, and I feel proud of myself that I was able to actually step up and volunteer to save my country during those dark moments.
I mean, it's incredibly brave to volunteer and put yourself in harm's way. But obviously, your professor, the infectious disease doctor, he seems to have inspired you to do the work. It's so apparent in the way you talk about him that you all respected him enormously.
Well, indeed. He was a hero. He was a national hero, and we regard him highly. Really, really, truly reflect the sacrifices he made and how he was the first to be shut down by Ebola. That is something that we, as an association, we reflect strongly. There have been a lot of local tournaments done in his name, trophies done in his name, and we still continue to reflect. And up to now, his monument, his grave is at the first only treatment center in the eastern part of Sierra Leone, Kenema.
I mean, during the time, you said you've sort of explained how isolated you were as a volunteer, people that you knew didn't want to see you because of their concerns and the food that was brought to you. So you were very isolated. Was there any support? Were you very much left on your own?
Well, we had support, but mostly when we go to work, and weekly, after every 2, 3 weeks, we'll have orientation, not much of a mental health assessment, but we are, appreciating our effort, our sacrifices, and asking us that was not the end, and the Ebola will definitely come to an end, and we'll go back to our normal life. But let's continue with the national duty. And so we had support from our colleagues, in the field. And of course, that was not only me. That was each and every one of us that actually was on the front line. And we definitely understood the situation because the case fatality rate was really high for Ebola, and people we are dying that we know them. We are seeing patients affected at end stage, bleeding from all the orifices, helpless, hopeless, in communities, at treatment centers. So we actually knew what we were doing, and we actually understood the concern and the way people behaved towards us as frontline workers. So it's about people's safety. So it's something that we
Yeah,
never took personal, but that is something we reflect on and believe. We're proud that we are able to support, and we are still here today to actually give
yeah,
a talk on some
yeah,
of our
absolutely.
experiences.
I mean, it just sounds so harrowing. And it's interesting. We read a lot about the sort of stigma of survivors of Ebola, but obviously, you as health workers, there was some sort of stigma about you treating people too.
I say I could still remember during the outbreak at the treatment center, the number of patients, families, children, women, lactating mothers
Mm,
coming at the triage, helpless. Tell you, it's I had several emotional breakdown during the Ebola outbreak, and some of those moments I really don't want to reflect on them. But outbreaks like VHF is something that I pray you do not get, especially the kind of strain surrounding heart.
mm,
It was terrible. It was emotional. It was traumatizing. The only thing that inspires me that was to see that I was helping, I was giving back to my people.
yeah. It's just incredibly brave.
I was supporting MSF and who needed the support, and I was providing care. I was providing the insight into, for people who we are the only hope after God. After God, we are the only hope.
Mm,
So some of them went into the treatment center with no hope, and I was glad. I was glad we actually helped. Yeah.
it's difficult to imagine what it must have been like to keep doing that. I mean, knowing the risks you were facing. That really says something about your commitment to the people you were caring for. Is there a particular patient that you remember or any incidents that you remember from that time?
Yes, at MSF Switzerland, there were three patients. Okay, the husband, the wife, and their little kid. I think was a girl around 6 to 7 years, and the the father was the one who was bleeding from the mouth and hopeless. They all came down the ambulance, and I took the case investigation form. I was in the scrub and I went. The man could barely talk, so the wife had to give me all the information, and they were helped into the isolation unit.
Mm,
And of course, they were epi-linked. They were also coming from a community that we had several positive cases. And can you imagine the man, the patient, the husband who actually came hopeless was the one who survived.
he
And the
survived.
other two later on, yes, he survived. And the other two who were actually working, the kid and the mother, they died.
Oh, it's just,
And I could still remember I could still remember this strongly. And this was at the heart of the outbreak in Freetown,
mm,
with MSF Switzerland. So there are so many instances, really, so many
mm,
instances. It was terrible, I'll tell you. It was.
mm. Gosh, that's so powerful. That must have been incredibly hard to go through, particularly knowing there was so little you could do. And thinking about patients that do survive, like the gentleman you just described, there's a lot for them to cope with post recovery, physically, and also the sort of social stigma associated with having had the infection, isn't there?
For the first time, you have a disease of such. I mean, we do not understand holistically the science behind. Even when you survive, you don't know whether you still have the virus in each of your different blood components. So we are unsure, and even though we had the technical expert, who we are advising on practices such as sex and other things of survivors. Because, I mean, there were ongoing research to see that we do not have an re-emergence of disease outbreak or maybe reinfection as a result of maybe some of these unknown findings, because we do not want any survivor to maybe pass on the virus to someone from either the semen or any of the body fluids.
Yeah, there were a few cases of persistence of the virus and reactivation. And I think there was a case of a possible transmission from an infected survivor about 1 year after recovery.
Yeah. I mean, we have a lot of those. So I'll say it's often out of fear. It's often out of genuine concern that you might have to stay off from someone who has survived, or you might have to be cautious, interacting with someone who has survived from Ebola. And you could see them, definitely those who survive, those who actually progress through the stages of Ebola infections. You see them, they are not the same. You definitely know that they are not the same. Yeah, you see their eyes, you see their mucosa, and you see the scars, the psychological scars, from the life struggles they go through from one treatment center or from one isolation unit to the treatment center, from one phase of the disease to the other, the multiple organ affections, are actually told, I mean, we are all over them. So
yeah, it's becoming clear, isn't it, that survival doesn't necessarily mean full recovery, with many experiencing something that's now being called post-Ebola syndrome.
Yeah, it was a traumatic moment for the survivors and even those of us who are in contact with them.
And even to this day, do you find that there is still?
Well, it's died down a little bit. We moved on, so it's natural. We moved on. But what it tells us is we have to really be alert and be prepared and to prevent. But if it does, to also see how best we could stop it as soon as possible before it affects such a large population of the country.
Because I mean, I think that's partly been in the current outbreak. It took quite a long time before it was recognized.
Yeah, it did. Yeah, so that was just the stage of preparedness we are, and also the capacity we had. So our response effect actually correlate to the capacity we have, which is awareness, preparedness, the planning, the management, the human resource, and everything. It was a health system challenge. So I think we are now much prepared compared to the 10 to 15 years ago.
As the clinicians are responding to the outbreak in DRC, do you think that they've learned the lessons from previous outbreaks like the one in Sierra Leone?
Yes, I'm sure, because outbreak is an outbreak, emergency is an emergency. And I would say infectious disease such as VHF, viral hemorrhagic fevers, is the only disease outbreak you prepare for, but wish it doesn't come.
Yeah. Because
when it comes, a lot will happen. So, and I believe we have a lot of consultants who we are here, specialists who we are here doing our outbreaks. They are in DRC today with different organizations. And I believe the lessons they've learned are being passed on to the responders in the field in DRC and other countries. And I also believe the development of certain vaccines, Ebola vaccines, that actually resulted from the outbreak we had in West Africa, Sierra Leone to be specific, might not be helping, irrespective of the strain, because the virus is mutates, and they take different character, different attributes, and these attributes affect the body differently. So I'm sure the lessons gathered from this, and also looking at the science, they might be responding more appropriately, and I'm sure they are.
That's fantastic. Is there anything that you would like to pass on, any pieces of advice that you'd give any young clinician who's caught up or wants to get involved with caring for patients during an Ebola outbreak, like you did, volunteering as a medical student?
So yeah, thank you very much. I think my advice to clinicians or other public health officers responding to disease outbreak wherever you are, then the first thing is to follow the standard operating procedures, SOPs, and guidelines developed. And in disease outbreak or whatever setting you are, there are always two guidelines, the tangible documents and your colleagues, your senior colleagues around you, the consultant, the specialists. So use these two to be your best guide. Then follow the IPC procedures and consider your safety comes first.
I think that's hugely important.
And your safety comes first. And maybe the final one is, the work you are doing is not an ordinary work. It's a national call. It's a humanitarian work. And you have your reward in many ways. And one might be to stay longer, to share your knowledge, your experience, and also to be one day recognized as someone who has contributed immensely to your country development. So that's just my advice. Thank you very much.
Oh, thank you so much for sharing your experiences with us today, Yusuf. Your insights are amazing and invaluable, and I'm sure anyone listening to this will take a great deal from them.
Thank you.
Thank you for listening, and goodbye.
Goodbye.